Hi, it's Dr. Janet Pope. I'm an At Room Now reporter, and I'm reporting in Milan for EULAR 2023. And there's a late-breaking abstract I wanted to tell you about because I think it has a couple take-home messages. So my provocative title is "Should JAKs be ticked off?" So this is late-breaking abstract number 0001. And what it was a phase 2 randomized controlled trial of a drug that is half TYK2 and half JAK1. That's sort of the potency of it. And right now it doesn't have a molecular name. It's something like LT018, but it doesn't matter the name. I just want to tell you about it. So this was already looked at prior, and now they did a phase 2 randomized controlled trial in rheumatoid arthritis, difficult to treat RA. Almost half the patients have been exposed prior with their active RA to TNF inhibitor, and about a third or so were exposed prior to a JAK inhibitor. So in this study, it was 4 arms, it was head-to-head, and it was monotherapy. And they compared tofacitinib, 5 milligrams twice a day, or this new molecule that is a TYK2 JAK1 inhibitor, and they compared it at 10 milligrams a day, 20 milligrams a day, or 30 milligrams a day. And it had a very firm ACR outcome measure of an ACR 50, the proportion meeting it in each arm. So what did they find? First of all, tofacitinib performed as we would expect, getting a decent outcome. However, the 10 milligrams of this TYK2 JAK1 molecule, the LT-18 molecule, it had basically the same effect numerically, in my opinion, as a JAK at tofacitinib, 5 milligrams twice a day. But when you looked at the 20 and 30 milligrams, what you found was that the ACR 50 started incrementally getting even higher. And that was true with the other outcomes. There weren't any safety signals that we would think about differently with JAKs and the other TYK2. There is a TYK2 that's already marketed in psoriasis and psoriatic arthritis. So number one, this molecule has promise, and it looks better in these difficult to treat patients. However, 2 caveats. It's single monocentric in China. Will our patients respond the same in other countries, other ethnicities? I don't know. Number 2, it is only a phase 2. But number 3, what's really important is about a third of the patients have been JAK exposed. So maybe a TYK2 plus JAK effects might be better than a JAK. So maybe the cards are already stacked against tofacitinib. But even more importantly, he didn't tell us, the presenter, on what proportion of patients were already exposed to tofacitinib. So I asked him the question, were patients exposed to tofacitinib or just the other JAKs? And he said, nope, some were exposed to tofacitinib. So if you have a drug that doesn't work and you randomize to try that drug again, it might not work as effectively. So the take-home message that is really kind of exciting to up the ante on the drug, on the ACR response level, is a bit dampened by these caveats. And if there were only 2 people exposed to, say, tofacitinib, because we know JAK to JAK can sometimes work of other JAKs going from one JAK to another, versus 30% of the population, that's a real difference in interpretation. So I think more will come. I think this was an important late-breaking abstract to even say we can get the ceiling better over time if we have novel molecules. So please follow us at Room Now. I'm at Janet Bordeaux. Thank you.